Hello, and welcome back to the diseases of the skin and eyes. Remember that we need to know the microbe type, the causative agent, the reservoir, transmission, and then the signs and symptoms, at least the ones that are unique to this particular disease. So we ended with smallpox in the last part of this chapter, and we are starting off here with wart-like eruptions called papillomas. So essentially, papillomas just mean warts. Now, this is not the same as genital warts. And we'll talk about that in a few chapters. In fact, it'll be the kind of cherry on top of the semester. The very last chapter that we talk about will be STDs and STIs and all that good fun stuff. So these papillomas or warts that we might find on the skin are caused by a virus called the human papillomavirus. There are roughly 100 types. This is the only one I want you to know. So kind of a little thing is HPV can also cause genital warts, but again, different thing there that we're talking about. The reservoir that we find these warts in is humans. Something you'll notice that is not included is frogs or toads. That is a common misconception that you can get warts from those animals. That is not where we get papillomas from. The transmission is going to be through direct skin contact, usually through auto-inoculation, so essentially touching one part of your body that is infected with warts and then touching another part of your body and then moving those warts from one part to another. Indirect skin contact can also be a way that warts can spread from locker room floors, so making sure you wear sandals when you're walking through a locker room, to touching unclean gym equipment, so making sure you clean gym equipment beforehand and then after you are done, and then towels or maybe through sheets or bedding of some kind. And then the incubation is 1 to 8 months for these guys. There are three kind of categories of papillomas that I want you to know, as far as where we find them, and what they look like is going to fall under our signs and symptoms. So we have common or seed warts. These are going to be relatively painless but elevated. They're usually less visually attractive. They're kind of ugly, but they're harmless, is what I'm trying to say here. They'll grow usually on the fingers, possibly on the face, but usually we see these on the fingers, and you'll kind of recognize this look when I show you a picture here in just a minute. Plantar warts are going to be particularly painful papillomas. They're very deep burrowers and kind of latch onto a nerve, are usually found on the bottom of the foot, like the soles of the feet, and so they burrow pretty deeply into those areas. In order to remove them, they have to essentially be carved out of the body. So they are particularly painful versions of papillomas. And then we have flat warts. These are usually kind of like a birthmark. They're smooth, sometimes skin-colored lesions on the face or trunk or knees or elbows, and can often be misinterpreted as being like scars from pimples, but they are usually flat warts. And again, I have pictures to show you here in just a minute. The bad news is we don't really have any form of prevention, just kind of ways to avoid getting papillomas. So avoiding locker room floors with our bare feet, again, cleaning gym equipment, good hygiene, that kind of thing. There are a handful of home remedies in essentially treatment, but there are also a ton of ways to remove warts. That is not a guarantee that the wart is not going to come back, though. So some home remedies, different salicylic acid preparations, potentially, and don't quote me on this, potentially adhesive tape, like duct tape. Just as a little PSA, this is not for genital warts. So potentially wrapping your fingers in adhesive tape could help with that process, as well as different types of surgeries. As I mentioned before, we could freeze off, burn off, or cut off those warts depending on the wart itself. All right, so that top picture is going to be those flat warts that I mentioned. Sometimes can be misinterpreted as pimple scarring. We have to the left on the bottom those plantar warts. Those are those very deep burrowing warts that get into the bottom of the foot and usually have to be carved out, cut out to be removed. And then the more common or seed warts that we see on the hands to the right bottom picture there. So potentially something you've seen before on hands. That is what we are talking about. Moving on to MRSA, or multiple resistant S. aureus. So something to make a note of is that this is not really a disease, it's a bacterial infection. And the causative agent is a specific strain of Staphylococcus aureus that is antibiotic resistant, because gentle reminder to you, we are covered in S. aureus. Pretty much everybody is. However, not all S. aureus is MRSA, but all MRSA is going to be S. aureus. So it's kind of just when this S. aureus kind of goes evil or bad, if you want to think of it that way. The reservoir is humans, and the transmission is one of two ways. It could be a healthcare associated MRSA, where it's a nosocomial infection. And this one makes a lot of sense because this particular strain is going to be found in an area like a healthcare facility that becomes resistant because it's constantly being introduced to those antibiotics over and over and over. Meanwhile, a community-associated MRSA is going to be a little bit different. This is going to be spread by skin-to-skin contact instead of through healthcare devices, potentially through a surgery or tubing, such as a catheter. This is going to be from person to person. It starts as essentially a painful skin boil that will lead to a carbuncle, which is going to be a hard, round, deep inflammation of the tissue. So it is important to remember with the transmission that there are two types of ways to contract MRSA. So healthcare associated and community associated. Healthcare associated being through procedures or devices. Community associated is going to be skin-to-skin contact. Now, what we're looking for with signs and symptoms of MRSA is something that looks kind of like a pimple, but essentially this is going to be an infection that our body, our immune system, is just not strong enough to fight off. So that area where that pimple or that boil or bump is could be red or painful, warm to the touch, swollen. There could be pus or other fluids. And it can lead to a larger pocket of pus, such as an abscess, or it could lead to what becomes a carbuncle, which is a hard knot that is filled with the bacteria. However, some things that this particular sign might look like is a spider bite. or another type of bug bite. So this is kind of commonly a thing that gets mistaken for MRSA, or vice versa. I'm sorry, that MRSA gets mistaken for spider bites. So patients may come in with a small red bump, say, I don't know, I just got bit by something and it just didn't go away and it's getting worse. Well, then it's probably not a bug bite. It's probably MRSA, especially if it's getting worse. So the prevention is going to be proper healthcare procedures, making sure to follow those proper sanitization procedures. The treatment itself is potentially multiple rounds of antibiotics all at once, sometimes 9 different antibiotics. And if you have the time to be able to run tests on that strain of MRSA, like a Kirby Bauer, just to figure out what is going to work for this strain, that's great, but there's also a good chance you don't have time. So we kind of just have to throw whatever we have at it that might work, just to see what works, which isn't great for the patient because, of course, throwing that many antibiotics at them is going to mess up their home team, potentially cause other issues, but at least it takes care of the MRSA, which is a particularly big issue too. Moving on to large pustular skin lesions, we have 2 of them that we're going to talk about, leishmaniasis and cutaneous anthrax. Leishmaniasis is going to be our first protozoan condition that we're going to talk about it. That is going to be the causative agent Leishmania species. That's all I want you to know. The reservoir is various mammals, such as mice and hamsters, which we're probably going to have more association with than sloths or possums. But it's what those guys are carrying, which is potentially sand flies. So these flies are the vector, and these animals are typically going to have these little critters crawling all over them. And the sandflies have this protozoan living inside them, not affecting them, but if they bite you, they can pass on that particular protozoan, not dissimilar to how malaria works. So some signs and symptoms are pustular skin lesions, which can be cutaneous or mucocutaneous, or can become systemic, meaning they start in one area and move to the other. Most of the time, that is the case. So sometimes they could be in the mouth or vagina for that mucocutaneous area that can be affected and then move cutaneously or vice versa. The prevention is just avoid the flies or the animals that carry those flies, because there is no vaccine. The treatment is kind of nice because there is an antiparasitic medication that can be started, but be probably best just to avoid these little critters to begin with. And here we have those sand flies containing that protozoan, the Leishmania species of protozoan, and where they bite, that's where that infection is going to develop, where we're going to see those large pustular skin lesions. That moves us into cutaneous anthrax. So the microbe type is a bacteria, which is Bacillus anthracis. The reservoir is the environment, typically the soil. The transmission is actually the endospores of the bacterium being inhaled or entering a small cut in the skin. And that is how this endospore from the bacteria gets into our system. Now, you probably know that there are different ways that anthrax can affect us. The first is this cutaneous type of infection, but we can also inhale it. It can also be ingested. So either way, not a good time. So let's look at the signs and symptoms. We see a papule that starts to become something called necrotic. And that means that the flesh surrounding the papule or inside the papule is starting to actively die. So it will start to turn black as that flesh necrotizes. And later we see the rupturing of that papule and it opens up and we can see that black dying flesh on the inside, which I have a few pictures on the next slide to show you what that looks like. Now, if left untreated, 20% of cases become fatal. And essentially the concern here is that this necrotic area of tissue is killing the area around it. Once it becomes painless, it's due to the tissue being dead. And you might be thinking, oh, it doesn't hurt anymore. That's probably a good thing. Nope, that is bad. That means that the infection has now killed deep enough. It is now killing the nerves and whatnot in those deeper tissues. That's not good. So prevention, vaccines exist, but typically are only given to individuals that are high risk in areas that might deal with soil or environmental factors that have anthrax in those areas. Treatment is antibiotics. However, if the infection gets bad enough, you might have to look at surgical debridement, which means essentially just scraping off whatever dead tissue is there, so that it doesn't keep spreading to that living tissue, which can be a particularly bad experience, particularly painful. So here are some images of cutaneous anthrax. We can see those papules rupturing, and we can see that necrotic tissue, that black dying tissue inside of the papule. Very likely most of these situations where we're going to have to remove a lot of that tissue. It's going to leave probably a pretty big scar. That's very painful too. Again, we want to feel the pain. That means it is not getting as deep as it could potentially get. We want to stop it before it spreads and gets deeper. Naturally, your head might be thinking, well, necrotizing lesions and flesh, that kind of sounds like a flesh-eating bacteria. And so, of course, we have to talk about necrotizing fasciitis. So this is a bacteria type. The causative agent is something called strep A or group A streptococcus or gas. It has a handful of different names. You can pick whichever one you want to remember. The reservoir is humans, not the environment. The transmission is direct contact with an open wound. And now that's a little bit confusing what I mean there. And what I mean is that this bacteria gets access to the deeper tissues of a wound that is exposed. So when we talk about prevention, the prevention is going to be good hygiene of wounds. So really good hygiene with wound care is going to be the big thing. Keeping your wounds covered with clean bandaging and making sure that those wounds stay clean, because we don't want this bacteria to get into an open wound and get into those deeper tissues. So some signs and symptoms are going to be redness and swelling, some severe pain, and then kind of the big thing here is going to be a purple or blackened skin surrounding the wound, blisters or bullae developing near the wound, and that is going to be that very telltale sign of this flesh-eating bacteria eating away at the tissues. So it can latch on to a nerve as well and kind of jump around, move around, and then eat away at that flesh in that area. And that is kind of worst case scenario here. So the treatment is going to be aggressive antibiotics and usually surgical debridement because we have to get rid of that dying flesh that is contaminated. Now, the survival rate is about 70 to 90% with treatment. Without treatment, mortality rate is about 100%, which is very high, but it makes sense because this guy will just keep going unless it's stopped. Now, I did have a picture to show you of the necrotizing fasciitis, but due to some restrictions, I wasn't able to show you. So if you have the notes, fabulous. Potentially you've seen this in class. But if not, I guess look up necrotizing fasciitis on your own time and, look at more wild photos if you feel so inclined, or more tame photos if you want to do that. So anyway, we are moving on to mycoses of the skin and mouth, which is moving into fungal infections. So there are three kind of categories that a fungal infection is going to fall into, and it's either going to be kind of sorted by the location or by the type of fungal infection. So you have cutaneous, which is going to be the outer layer of skin. Typically, we're going to have no pain here. So that is going to be an infection, a fungal infection of the epidermis. Then we have the subcutaneous, which is going to be the deeper layers of the skin, so the dermis and the hypodermis. And this is typically where we're going to see more painful infections. Typically, this is going to be a fungal infection entering through some type of abrasion or trauma to the skin. And then candidiasis, which is going to be a yeast infection, typically of the vagina or skin or mouth. And sometimes this type of infection will move around, start in one area and move to another area. And typically what we see is these areas that we have these yeast infections are warm, wet environments, so perfect already to have a home team yeast called Candida aureus. Basically, act against us, for lack of a better term, and we have an endogenous infection. So it's essentially our home team turning against us. And again, these fungal infections are going to be slightly harder to treat because they are eukaryotic cells like you and me. So if their cells are similar to our cells, then using a strong medication is going to mean that we're going to hurt our own cells in the process, and we don't necessarily want to do that. Okay, here are some examples of common cutaneous mycosis infections. So again, areas where we don't see much pain because these are particularly superficial infections. So ringworm, athlete's foot, barber's itch, jock itch, couple examples of where and what we're seeing. You don't have to memorize these. We are going to talk about a few of these individually, just a couple examples. Here's a couple images of a subcutaneous mycosis, that fungal infection that is going to be deeper in the layers of skin. So the dermis or the hypodermis, we can see on the left there that that particular fungus was picked up by the lymphatic system or a lymph vessel and is moving along down the leg, which is kind of terrifying to see. But yeah, so remember that this guy is going to be moving deeper, and we are going to see pain with this particular type of infection. And then candidiasis, this is going to be a yeast infection. So any type of candida infection, which is a type of yeast. We can see this in the vagina or folds of skin, so potentially in elderly patients or obese patients, anywhere where skin can create a fold, we can see yeast forming and growing, causing this type of infection, as well in Areas like the mouth or the vagina is also a common area for yeast infections. All right, starting off with ringworm. Remember, we are talking about a fungus, so that will be our microbe type until I say otherwise. The causative agent, I want you to know 3 different types of fungus that cause ringworm. Trichophyton, Mycosporium, and Epidermophyton. There are 39 different species that do cause ringworm. However, I just want you to know those 3 as the causative agents. The reservoir can be us, it can be the environment, and it can also be your pets. You can pass this or get this passed on from your pets to you because they can go rolling around in the environment, in the soil, and then you're loving up on your pet. And then, you get ringworm on your face or your neck or your hands or your arms or wherever. The transmission can be direct or indirect contact with an infected human or animal or from the soil. Now, these signs and symptoms are kind of how ringworm gets its name. It's a circular rash where the middle of the rash kind of has this nice little depression. Has everything to do with how the spore lands on our skin and then creates a ring of growth. It's not dissimilar to like how mushrooms in the ground form what's called fairy rings. So if you're not familiar with what I'm talking about, look up mushroom fairy rings. And that's what happens. A spore lands and then the mushrooms grow in a ring. That is what's happening with ringworm, but it's on our skin, which is just kind of crazy and wild. The treatment is a topical antifungal treatment. You take it for a few weeks. The purpose of this treatment is that lotion causes your outer layers of skin to slough off more quickly, so that it causes the fungus to fall off your skin as your skin sloughs off. Again, the whole point of any treatment of a fungal infection is to not hurt the patient, because they're eukaryotic cells. They are the same type of cell we are. So if we use too strong of an antifungal, we're going to hurt our cells in the same process. All right, so here are some images of ringworm. We can see that beautiful ring, little fairy ring on the skin, forming that rash. And again, you can get it anywhere on your skin that you are exposed to that particular fungus. Scooting right into athlete's foot. Again, we're talking about a fungus. There are several species. I don't have a specific one that you have to know, just that there are several different species. The reservoir is humans and animals. Transmission is direct contact, sometimes indirect contact through shared spaces, items, and sometimes you can get you can essentially infect yourself. So let's talk about this for just a second. So direct contact, potentially you're being nice and you offer to give somebody a foot rub and they have athlete's foot. Now you're rubbing all over their feet with your hands and you can get athlete's foot from someone's feet onto your hands and then spread it around that way. Now, you can get it through indirect contact by wearing someone else's shoes or, again, kind of walking around in a locker room or wherever with no shoes on. So, one thing to make a note of, maybe just for yourself personally, is that athlete's foot, this particular fungus, can live up to 3 weeks on a non-living surface. So, next time you walk through a locker room or you're going to a public pool or something and you have to go through the locker room, wear sandals. Just do yourself a favor and wear sandals. There's so many things you can contract. But you can also get this through an endogenous infection, essentially, is you can infect yourself. So this might be your own home team turning against you, is essentially what we're saying here. All right, some signs and symptoms. Very kind of obviously, we can have itching and burning between the toes, some dryness on the soles and heel and edges of the feet, maybe blisters, cracking. And this last one is kind of obvious, but I want you to add something to it, is that feet already have a bit of a funk. So we're not saying that all bad feet that stink are because of athlete's foot. Feet already have a stink. But when it comes to athlete's foot, this may be foot funk plus, like, add an old dirty bakery stink on top of it, kind of a yeasty smell on top of foot funk. So that is what we're saying with this bad foot smell. Now, prevention is keeping feet clean and dry and avoiding those areas that we mentioned before, those communal areas or someone with athlete's foot. Treatment would be antifungal creams, sprays, powders. There's tons of them that you can put into your shoes to prevent athlete's foot. There are also a handful of prescription medicines that you can get from your doctor. Okie dokie. So here are some images of some very tame athlete's foot. I removed a particularly gnarly one for fear that it would be censored because it was kind of a rough image of the skin between toes essentially cracking due to and peeling due to the fungus causing the skin to dry out. But you probably recognize this if you haven't had this situation. Maybe someone you know has had this with their feet. But it is important, guys, to always be looking at the different parts of your body that you don't always pay attention to. So looking at your feet is really important, and encouraging your patients to also look at their feet is equally important. Naturally, if we were talking about fungus on the feet, now we have to move to the complete opposite of the body and talk about a fungus in your mouth. So let's look at oral thrush. So thrush is going to be a yeast infection that is found in humans where we essentially cause the infection ourselves from the natural fungi living inside of our nose and throat and mouth. But it turns against us. So a good prevention is good hygiene, avoiding prolonged antibiotics or corticosteroid uses. The treatment is antifungal medications over several weeks because, again, we are talking about the type of cell that is the same type of cell as us, eukaryotic. So we can't go too harsh on these guys or we'll end up hurting our own cells. All right, a couple of more tame images that I can show you for some oral thrush is this white rash growing on the tongue, maybe the roof of the mouth, the cheeks. What we can see is very distinctly the fungus itself growing inside of the mouth. That is what we are actively seeing here. What this fungus growing in the mouth can cause is pain or burning, maybe a loss of taste, which if it's growing that heavily on the tongue like we see in that first image, absolutely. Dry mouth makes sense, but the big concern is going to be difficulty swallowing. Okay, moving into a superficial mycoses. Again, this is a microtype that is a fungus. The causative agent is Malassezia. This is going to be a type of fungus that everybody has. It's almost like a guaranteed that every human carries this fungus on their body, on their skin. It's part of our home team. But essentially, what happens is an endogenous infection where we infect ourselves. This particular infection is going to cause something that I guarantee you've had before and you know of. Whether you knew it, we have all had this before. So humans are the reservoir as well as animals in general. Why, yes, it is dandruff. That is superficial mycoses. So, this fungus that grows on our skin, typically in our hair as well, essentially just causes this infection that makes our skin flake off more, dries it out. It's just mild scaling that interferes with melanocyte production. It's not anything severe, but everybody's had it. There are a handful of different dandruff shampoos that have specific acids in them that will knock down the cells of the fungus so that you don't have as much dandruff. Just kind of depends. So folliculitis, psoriasis, and seborrheic dermatitis, or just dandruff, are just different types of superficial mycoses. Again, it's just a fungus that holds on to skin cells and creates flakes of skin. That's all it is. Just too much of that fungus is holding on to too much of those skin cells, is essentially what's happening. Alrighty, we are moving on from the skin, but not that much further from the skin. We are moving on to the eye. And I do want to go over a little bit of a reminder of what the eye and its defenses look like, in case it's been a minute since you've taken A&P. So the eye is going to be composed of the conjunctiva and the cornea as its most superficial layers. So we're not going to go any deeper than that, because once we enter the inner eye, that's where we have a sterile environment. We're not going to talk about that area. We're talking about the surface of the eye here, which is going to have a very similar microbiome to the rest of the skin. But the conjunctiva is going to be this thin membrane-like tissue that is going to cover the eye, except for the cornea. The cornea is going to be over the middle portion of the eye, where you have the pupil and your iris and all that good stuff in the middle. Now, the conjunctiva is going to act not dissimilarly to a sticky trap, because it has a bunch of fluids that are going to help lubricate the eye, and that is going to trap those microbes in that sticky fluid, essentially. Again, like a sticky trap. The cornea, however, is going to be this very strong outward shaped dome that is going to protect the iris as well as the pupil. Now, it's very thick. It's meant to be, because it is essentially a shield that protects those very important parts of the eye. So we have the conjunctiva, which is a sticky trap, and the cornea, which is like a shield. So more about the defenses of the eye. The tears produced by the lacrimal glands. So if you look at this picture, in the right part of the picture, technically the upper left part of the eye, if we're going by that person's perspective, is the lacrimal gland. Now, the way that tears are produced is so that the fluid flushes over the eye and down. And this is the best defense of the eye. So this product that we call tears are an aqueous fluid made of oil and mucus, and what this is going to be a constant flushing of the eye that will then drain into that lacrimal sac, and then thus into the nose, and either you swallow it or snot it out. It doesn't really matter. But essentially, we're constantly flushing the eye of microbes and debris with these tears, and any other larger particles, before it can even get in the eye, we use the eyelashes. So they kind of act like a broom. They sweep away microbes and dust and other particles before they even reach the surface of the eye. So these are the two kind of most important defenses of the eye itself when it comes to microbes. Remember that we used to think that the eye was perfectly sterile, except now we know it's not. There is normal biota in the eye, which is very similar to the skin, and it makes sense. Your skin is very close to your eyeballs, so all those microbes that are on your skin would naturally have very easy access to your eyes. And of course, what do we do with our eyes? We're constantly touching them or, adjusting our glasses or picking something out of our eyes, whatever. But it's very similar in our biota to our skin, to our eyes. Very, very similar. Now, when it comes to most infections of the eye, what we call this is conjunctivitis or pink eye. Now, this is a very kind of catch-all term because it's referring to any type of infection of the eye, regardless of the type of microbe that is causing the infection. So if someone says they have pink eye, don't immediately assume you know what type of microbe. Maybe ask for clarification because it could be anything from a bacteria to a virus, to damage, to allergies. Who knows what it is? So either way, conjunctivitis can be caused by all kinds of things. Different microbes and different agents essentially can cause pink eye. A great way to prevent pink eye is proper eye care, starting with contact lenses, which is going to be one of the biggest hurdles for a lot of people because, depending on your availability to eye care and contacts, if you don't want to wear glasses all the time, you may use your daily contact lenses more than once, and I'm not gonna be here to judge you. So just know you're kind of taking your eye health in your own hands. And the reason I am still talking while staring at this picture is because I care about you. So just keep that in mind that good contact lens use is going to be a good starting point when it comes to preventing yourself from getting something like conjunctivitis, as well as not sharing eye products like eye drops or mascara or eyeliner, things like that, or like eyeshadow brushes, things that you would put around your eye, or if you drop your makeup products in the bathroom, don't pick them up, blow on them, and then start using them again. That's probably a good sign that you need to get new makeup. When it comes to makeup products that go around your eye, it's a good thing to maybe refresh them once every blue moon. I know it's hard sometimes, but it's always good to get new products every once in a while because they are just growing microbes and can lead to things like conjunctivitis. Signs and symptoms are going to depend on the type of infection, and typically we're talking about the type of discharge as well as what happens when you sleep. So let's talk about it. With bacterial and viral infections, you have two different types of discharge. For bacterial infections, it's a milky discharge versus a viral infection, which is going to be a clear, watery discharge. Regardless, between those two types of infections, when you go to sleep, your eye is going to continue to make that particular discharge so that when you wake up, there is an excess of that discharge right at the eyelid, essentially gluing your eyes shut. So you have to pry your eye open due to that accumulated discharge that has now solidified on your eyelid. Now, if the conjunctivitis is caused by an allergic reaction, it'll produce a clear watery discharge. However, you will not have that eyes glued shut symptom like we did with the bacterial and viral infections. So an allergic reaction will just lead to that watery discharge, but not having the eyes glue shut. Okay, now we have a different kind of pink eye here, and it is specific to who gets it, and that is neonates. So brand new babies. So neonatal conjunctivitis is a type of bacterial infection that essentially gets pushed into the baby's eyes during the birthing process. This is typically going to be babies born through the vagina, so typically not a C-section. We see a transmission from mom to baby through the birth canal if mom has gonorrhea or chlamydia. Now, typically, we're going to test for these particular types of infections with mom, but if mom doesn't have access to care to check for these things, or maybe she didn't know she was pregnant, or she didn't know she was infected, or all kinds of things. Again, we're not judging. Then we might not catch this in time to prevent the baby from getting this bacteria pushed into their eyeballs as they are being born. So what we see is this milky discharge, the eyes being glued shut due to the gonorrhea and chlamydia or chlamydia bacteria in the baby's eyes. So prevention, again, usually we check for this, treat mom prior to the birth, then it's taken care of. Treatment, however, if we don't catch it, is antibiotics into the baby's eyes. So it's not the end of the world. It just looks worse than it really is. However, there are a handful of STDs that are becoming antibiotic resistant, like the superclap, which may lead to a particularly bad issue when it comes to neonatal pink eye, especially, again, superclap in a baby's eyes. I mean, that doesn't sound like a fun time. Okay, scooting right into trachoma or inclusion conjunctivitis. This is a bacteria. The causative agent is Chlamydia trachomatis. The reservoir is humans and the environment, specifically water. It's almost always contaminated swimming pools is where we find this particular type of bacteria, and how it gets into the eyes, because we are still talking about conjunctivitis, is individuals opening their eyes underwater. We can also see this being moved from the birth canal to the eyes of newborns, but typically the vast majority of cases are individuals who open their eyes without swim goggles underwater in contaminated swimming pools. And no, chlorine does not kill chlamydia. So, think about that for just a hot second here. So let's talk about some signs and symptoms. Okay, so we've got a roughening of the inner surface of the eyelid, which is going to cause pain and the breakdown of that shield that covers the iris and pupil of the eye, the cornea. Now, over time, if that roughening of the eyelid, and you're constantly blinking and rubbing your eyelids over that cornea, can cause scarring, which will lead to blindness in the long run. That is why trachoma is the leading cause of blindness worldwide. That is crazy, guys. That it is due to the scraping, essentially, of your rough eyelids over your cornea because you opened your eyes underwater in a chlamydia-infected swimming pool. So just kind of keep that in mind. Prevention and treatment. Prevention is going to be wearing goggles at a swimming pool. And don't open your eyes underwater. I mean, don't do that, because what is there to see anyway besides, dirty band-aids and people's feet and, who knows whatever else is going on in a swimming pool. But, there's not much to see, right? You can treat trachoma with tetracycline, so antibiotic treatments. Now, the next picture, some people are going to hate it. I know I do, but here we go. In the first image, we can see a relatively healthy eyelid, where in the B labeled image, we can see some lumpy bumpies starting to form there, as well as a little bit of inflammation. Now, in that third image, C, we can see a ton of inflammation. So if you've got lumpy bumpies and your eyelid is becoming inflamed, you are now pushing the lumpy bumpies, that roughening surface of your eyelid, against your cornea, the surface of your eye. Now on D, we're starting to see more of that roughening of that surface, where the eye is probably getting a real scraping essentially from the eyelid. Following that, in E and F, we see that roughening of the cornea and scarring as well, leading eventually to potentially blindness if it is not treated quickly after that point. Okay, last but not least, for this section, we have keratitis. This is going to vary for the microbe type. It just depends. Could be a bacteria, could be a virus, could be an amoeba. Typically, we will kind of focus on this amoeba here, because it's going to kind of come back every once in a while when we talk about this guy. The reservoir is going to also vary depending on what type of microbe it is. And then again, that transmission is going to vary as well, depending on the microbe type. So bacteria need direct contact. A virus can cause keratitis without trauma due to a redirection of oral herpes. So essentially, this virus is going to jump on a facial nerve, and that is how it's going to get into the eyeball. And then a very common one is going to be an amoeba living in a freshwater source, which is usually tap water. This is very common, guys. Pretty much in every form of tap water, you're going to find this acanthamoeba. And what people do in moments of, I know your head's in the right place, using tap water to clean your contact lenses, but this is going to be the reason why you're not going to do it again, even in dire circumstances, is that because this amoeba lives in tap water, and let's say in a moment of weakness, you clean your contact lens that falls out of your eyeball and onto the ground with tap water. You just rinse it off underneath the sink instead of using some type of contact lens rinse that is a proper contact solution, let's say. So you use tap water instead. And this amoeba just kind of rides along, just living its life, gets onto your contact lens, and then you put the contact lens back into your eye. Now, what happens is the amoeba itself is now trapped between your contact lens, which is a very thick material, and your eyeball, which is not as thick and not as hard to burrow through to get out. So the amoeba, of course, given two options of stay there and die or burrow and live, is going to burrow through your eyeball because that is the only option that it has. So this is typically how we see keratitis form when it comes to that amoeba. So some signs and symptoms. So we've got damage of deeper eye tissues, can occur and lead to complete corneal destruction. And that's kind of the big thing here, is the cornea becoming damaged, leading to deeper tissues becoming damaged. So the worst symptom that we can see happen is that blindness, which makes sense. Prevention is going to be good hygiene. Treatment is going to be medicated eye drops, and we can also have corneal transplants to kind of remedy whatever damage has been done to the cornea itself, depending on what type of infection we have. Now I do have a few diagrams here for your leisure, viewing pleasure. So these are kind of most of the things that we talked about, some color coordination of the type of infection and where you're going to find them. What causes each type of infection. I think this is going to be a helpful diagram to help you summarize each end of the chapter, maybe if that'll help you study. So here you go. And while this diagram is not so helpful maybe for studying, it's still pretty neat. It's showing deadliness and communicability of different diseases of the skin and eyes, basically showing us that it's easy to spread. It won't kill you right away, because if a particular disease is wanting to spread, if the host is dead, it can't. So the easier it can spread, the more likely it's going to keep the host alive for as long as possible, because otherwise it's counterproductive. But anyway, we made it through skin and eye diseases, so make sure to be using those study materials that I have offered you. Keep everything as up to date as you can, and we'll keep on moseying through these chapters until we get to the end of this unit. This will be a pretty intense exam, so I would just keep on studying every chance you get, whenever you can. So make good choices, guys, and if you have any questions, please don't hesitate to reach out. I am here for you guys.